One is neutropenia, which we can treat with growth factors. Infections in general, bacterial infections, and treat those as one would normally, but get on top of them quickly. If you use pneumocystis and viral prophylaxis, hopefully you won't see much of that. And then there's this pattern of immunologic toxicity that occurs with liver function abnormalities in about the second month on therapy, which generally resolves if you hold drug, and you can usually restart at a lower dose in the relapse setting. And then there's a diarrhea or colitis that can be quite severe and is often delayed, a median of 7 months into therapy, but can even occur at 2 or 3 years. And if that happens, you have to really have a low threshold for holding drug. And usually we start oral budesonide if it's not too bad, oral prednisone if it is bad, to control it, get it under control. And then generally you can restart idelalisib at a lower dose, but usually I do it while tapering the prednisone or tapering the budesonide. Sometimes you can taper that off and continue idelalisib, but then if the patient recurs, many times I'll leave them on a very low dose of budesonide, like 3 milligrams a day or 3 milligrams every other day, while they're on the idelalisib to control any of the diarrhea. And there is, in addition to pneumonias, a couple percent incidence of a drug-related pneumonitis that's steroid responsive. So again, a patient comes in with pneumonia, hold drug immediately, work up for infection, treat for infection. If they're not getting better, and it looks like an interstitial pattern on CT, generally I would initiate steroids. And usually that fixes the problem pretty quickly. And most of the pneumonitis patients I have actually been able to put back on idelalisib without recurrence while on prednisone and taper the prednisone off. And generally they don't recur, actually, in my experience.